Bonjour, Madame et Messieurs. This is all my French, so good morning to everybody. I am Moshe Mittelman from Tel Aviv. Here with me, my co-chair is Professor Rick Solari from Gustave Roussy in Paris. And we are happy to chair this session. I think the last day of the meeting after this very hectic and busy 3 days is always the most difficult day, and I admire those of you who came here on Saturday morning instead of anything else. So stay with us. Believe me, it will be worse. We have excellent 7 presentations, and I think with no more introduction, I will be happy to introduce Dr. Eric Padron. Eric is from Moffitt Cancer Center in Tampa, Florida. He is the scientific director of the hematologic malignancy, as well as many other jobs. I won't go over the long list. And he has been a pioneer in the field of CMML, and he will tell us today about very interesting models that they produced, patient avatars to guide clinical trials in CMML. Stay with us. Eric, please.
Thank you. Thank you for the kind introduction. Thank you to the organizers for the invitation to what's been a really fantastic meeting in a great city. I'm going to talk about one of our interests in CMML and in our lab, and that's in the role of patient avatars in CMML research. So I'd like to frame the discussion by reminding all of us that there are a lot of options for quote-unquote avatars or models, right, for lack of a better term. So one way of looking at it is the source of the tissue, the source of the model of leukemia, and that can be human or mouse, right? And these can be cell lines, iPSCs, or primary cells that have been freshly isolated from bone marrow aspirate. And in mouse models, the same thing could happen as well. And then there are a lot of ways to use it. So that's the other layer that I wanted to frame. Of course, there's liquid culture, there's colony formation assays, there's emerging data in the context of organoids, there's heterotopic transplants, xenografts, there's orthotopic xenografts, and I purposely, I don't know if this pointer works, but I purposely put them in this order where F2 orthotopic transplants are here and F1 orthotopic xenografts are here, because I do think that while PDX models have their role, they have their role with the right questions. And so if the question involves and is important to have high fidelity, then this side is probably the model to choose. And if throughput is what you're interested in, then perhaps this side is what you want to choose. So all of these are potentially useful in the context of the right questions. And what I hope to discuss are maybe not the right questions, but the questions we think are viable to answer in PDX models. So what I'm going to focus on is essentially these green boxes. So patient-derived cells xenografted into mice and not serially passaged, and I'll talk about why in just a second. So we've generated quite a bit of CMML PDXs since 2018 now. So we've generated, and so we have a few pros and cons that we can share. We've generated approximately 1,400 PDX from approximately 66 patients from centers that have graciously sent samples, testing a variety of agents. And one of the things that is very advantageous, there are many limitations to studying CMML, but one of the big advantages relative to MDS is the extremely high take rate if you use NSGS mice that secrete human cytokines, human GM-CSF, IL-3, and stem cell factor. And in that context, across all our PDX models, the average bone marrow human CD45 engraftment is somewhere around 40%, which is important too. It's not 1 or 2% like you see, for example, in acute myeloid leukemia and MDS. It's 40%, so you can actually do preclinical therapeutic credentialing and use engraftment as a reliable readout. And so we've also done some transcriptomic profiling and sequencing to show the fidelity of these models, not only pathologically and immunophenotypically, but genetically. And I'll talk about a few of the ways that we've shown that. And the other thing, too, is we've generated all our PDX models from cryopreserved cells, which is very practical, given the fact that in proliferative CMML, you get billions of cells, many aliquots. So it makes it actually quite feasible to do these CMML PDXs. The major con is you can't serially transplant. There's about a quarter of people, or a quarter of patient samples in which you could, but you cannot serially transplant as a general rule in CMML, which we think is both a pro and a con. The con, obviously, is you can't propagate the line. But the pro is that, we argue that in propagating those lines, sometimes these patient-derived models approximate cell lines better than they approximate the patient in which they came from. So when we test drugs, when we look at the model, we do it immediately in the first F1 transplant. NSGS mice have human cytokines. That's why CMML and grafts have used NSG mice. They do not. But they're super physiologic in their concentrations. And we think that may be leading to a differentiation effect. And of course, that could skew the HSPC composition. So that's a caveat as well. And that probably is partially responsible for the fact that they don't secondarily transplant. So these are just some data that show on the left flow cytometry that there is a characteristic myelomonocytic skewing in classical monocytosis. But I think most impressively on the right are sorted human CD45 positive cells sequenced and matched against the patient sample from which they were derived. And what you see is a fairly good recapitulation not only of the spectrum of somatic mutations, but their variant allele frequencies. A case vignette I always like to give about our PDX models is not one with CMML. It's actually one with juvenile myelomonocytic leukemia. As many of you know, this is an exclusive RAS pathway disease. Unfortunately, occurs in children with a median age of 2 and has a 50% overall survival. This particular series of PDXs was done in collaboration with Elliot Stiglitz at UCSF. And what we noticed in this particular patient sample is that it was the most aggressive sample we've had, even more than cell line xenografts. The median survival of the mice were 14 days. There was robust engraftment, as you can see by immunohistochemistry. And it recapitulated a lot of the features, including the myelomonocytic skewing in the bone marrow that the patient had. But I recall sitting down with Elliot and telling him about the case and saying, one strange thing about this PDX is that at necropsy, all the mice had alveolar hemorrhage. There was blood macroscopically visible in the lungs. And he said, well, this patient unfortunately passed, actually had an autopsy, and one of the seminal findings was alveolar hemorrhage and blood in the lungs. And you can see here the histology and the macroscopic view of both the patients and the PDX from which that patient was derived. And you can see that feature, quite rare, quite unusual, was recapitulated in the PDX. So what kind of questions do we ask? Well, we can put it in 4 categories. One is probably the most important, but also the most obvious, which is preclinical therapeutic credentialing. I won't talk about it, and I just list some publications in which we've done PDX models, mostly in collaboration with the community, many of which are here. And it's something we really enjoy doing and would love to collaborate, even more. If there's a preclinical target, please reach out to us. We're happy to collaborate and test it in PDX models. But I'm going to talk more about the other 3, which is corroborating clinical efficacy in phase 2 studies. One of the biggest challenges of CMML clinical trials is outside of this country, there has not been a randomized study, whether it be phase 2 or phase 3 in CMML, and that's for a lot of different reasons. So we're stuck with single-arm studies. And so one of the utilities of the PDX, we thought, given its high fidelity, is could it help corroborate the clinical efficacy in single-arm studies, and perhaps could be a paradigm used in other rare cancers in which randomized studies can't be done. Another is using PDX models to discern biologic differences that perhaps aren't apparent looking at human clinical genetic data. And then looking at prognostic models and can we validate them in the PDX? And I'll tell you what that means in just a second. So this is a study we did to corroborate the clinical efficacy as part of our clinical trial testing ruxolitinib, a JAK1/2 inhibitor in CMML. And what we did is we took the screening bone marrow samples and we xenografted 2 million bone marrow mononuclear cells into at least 6 mice and randomized those mice to receive pharmacokinetically equivalent doses of ruxolitinib or vehicle. So we were able to randomize these mice here. And then we compared overall survival engraftment in a variety of ways. So in the left panel here, you can see that when you look at response versus non-response by the MDS MPN International Working Group criteria, you see that the PDXs that were derived from responders actually had an improved survival compared to those that were non-responders, which was encouraging. And you can concomitantly see that there is a decrease in engraftment in those patients, in those PDXs derived from responders compared to the non-responders. But in this study, what I can tell you is most people really didn't qualify for overall response, in part because we didn't administer an MPN SAF, which is part of the response criteria. But there were a lot of people who had quote-unquote stable disease. And in fact, if you were on the study for more than 3 months, the likelihood was that you'd be on the study for, or on ruxolitinib for at least a year. So that was the median time, or median duration of therapy in that cohort. So if you actually combine those, the responses and those that had stable disease for more than 3 months and were on therapy, you still retained that recapitulation and corroboration of clinical efficacy. So that's one way, and there's a variety of ways that this could be potentially applied, and I'll talk about that just at the end. This is another example of corroborating responses. So these are MRI images of our PDX mice at a standard time point. Because we went out for survival, we thought it was important to image for spleen response, just like we do in our patients. And you can see that in a responder, there is a significant reduction in spleen volume in the CMML. This is just a NSG without transplant as a control, which was not seen in the non-responders, and that could be quantified here. So not only did it recapitulate by survival, but also by splenomegaly. What about prognostic models? So, I mentioned we've generated about 1,400 mice and had a variety of experimental approaches, but we thought, what about if we focus on patients who had bone marrow mononuclear, or PDXs that had bone marrow mononuclear cells by tail vein that were allowed to go for overall survival and either were not treated or were vehicle mice? And can we do a meta-analysis of all of these mice and ask whether the baseline human characteristics can be associated with the PDX outcome? So the baseline mutations, the baseline prognostic score against the outcome of the PDX itself. So one of the first sanity checks was it actually didn't matter, at least in an order of like 1 log, how much bone marrow mononuclear cells were injected with relative to survival. But what mattered, as was nice to see, was that high engrafters by bone marrow human CD45 had a significantly inferior survival than low engrafters. Another thing that was nice to see was that when you looked at mutations from patient samples and asked whether these mutations had prognostic significance in the PDX, you found that ASXL1 was highly significantly associated with inferior survival, and RAS pathway mutations to some extent the same, but the others, most common mutations that have been associated with CMML or Prognosis did not. And I think that's reflective a little bit in our knowledge in terms of molecular prognostic models in CMML, where ASXL1 is really nonsense and frameshifter mutations are really the only mutations that consistently show inferior survival. So it was nice to see in PDX that was recapitulated. But one thing was quite surprising and perhaps counterintuitive, was when we looked at the Mayo Prognostic Score, for example, we found that patients who have a low Mayo Prognostic Score have PDXs with the worst survival, so the opposite of what we would have expected. And even when you add ASXL1, which I just now told you was associated with adverse PDX survival, it still held. So the Mayo molecular model and the Mayo model had the opposite effect. So we started to ask, well, why is that? So we went through every parameter in the Mayo model: hemoglobin, platelets, monocyte count, circulating immature cells, and the only thing that popped out was an increase in platelet count. So if the patient had an increase in plate count, that predicted for high engraftment and poor survival. So it got us to think about what other features could be discerned from these high engrafting PDXs. So we went back and looked at a variety of our studies. So one thing that we did is we looked at the vehicle mice, so the mice that were not treated with ruxolitinib, and asked, was there any correlation to response and the engraftment of these vehicle mice? And it turns out that the high engrafting mice had the best response and the worst survival. So as shown here, again, suggesting that these high engrafting samples, perhaps because we use an NSGS model, could be a cytokine-sensitive high platelet count subgroup of CMML. In fact, when you do colony formation assays and you separate a patient aliquot based on whether they were a high engrafter or a low engrafter in PDX, you actually find that those that were high engrafters are extremely cytokine sensitive. In other words, without cytokines, no colonies. With cytokines, at least 30% increase in colony formation, suggesting that there's a subgroup of these that have favorable outcomes, high platelet counts, respond to ruxolitinib, and are cytokine sensitive. The last thing I'll talk about is PDX to discern acute inflammatory insults. So one of the things we're really interested in CMML is how does acute inflammation augment the HSPC composition, and how does it lead to disease progression? And what we've shown by single-cell analysis is that there's an inflammatory GMP population that's marked by CD120B that is associated with progression and is highly inflammatory. And so although we are currently prospectively testing whether this is associated with acute inflammation, which is our hypothesis, we were able to look at that in our PDX. And the way we did that is we generated our PDX as normal, allowed them to engraft, performed a bone marrow biopsy, and gave them one dose of 10 micrograms of LPS. And then after 24 hours, performed a necropsy to look at HSPC composition before and after. And what this shows on the right is a human-specific cytokine panel that shows that LPS induces these human CMMLs to secrete inflammatory cytokines, as you would expect. And what it also showed was because, and I just show the RAS pathway because those were the ones that were enriched for this process, but we were able to show that upon addition of LPS, you do see an expansion of GMPs and specifically an expansion of CD120 GMPs. And this has led to an observational study looking at following CMML patients and annotating acute inflammatory events and asking whether these are associated with prognosis based on this PDX data. So in summary, CMML F1 PDXs have extreme high fidelity. They're straightforward to do, and they recapitulate a lot of features of the disease. You can corroborate clinical response. Maybe that helps inform go, no-go decisions from single arm to phase 3 if they can be done, or maybe even provide some ancillary support during regulatory approval. ASXL1 mutations have prognostic significance in human and murine CMML. Surprisingly, high engrafting PDX constitute a subset of patients with favorable outcomes, high platelet count, cytokines dependence, and ruxolitinib sensitivity. And PDX models can recapitulate changes in HSPC after acute inflammatory events and have led to an observational study in humans to see if that's the case. Thank you very much.
Thank you, Eric. As you know, we have the discussion at the end, so we move to the second talk that will be given by Dorothe Selimoglu-Buet. She is using flow cytometry as a tool to decipher the pathogenesis of CMML, and she's going to explain us how we can use it also to better diagnose and stratify these patients. Dorothe.
Thanks, Eric, and good morning, everybody. I would like first to thank the organizer for their invitation to present you our work based on flow cytometry analysis of the peripheral blood in CMML. So first, the flow cytometry technology is a very interesting technology to decipher small population of cells and characterize them. And I would like to show you today that using this technology for the characterization of the population in the peripheral blood of CMML patients help us to improve the diagnosis and the prognosis of this pathology, and I guess help us to better understand this pathology and the mechanism leading to its development. As you can see here on this blood landscape, that we obtain by spectral flow cytometry using more than 30 different antibodies to clusterize the different population present in the circulation. We obtain different blood landscape for age match controls and CMML. And I will present you today two main differences, one for the monocyte and one for this little cluster of neutrophiles. So first, with the monocyte, it is now well established in the literature that thanks to the flow cytometry, it is possible to separate 3 monocyte subsets based on the expression of the CD14 and the CD16, 3 subsets with different functionality in the organism. The classical monocyte, the intermediate monocyte, and the non-classical monocyte. And compared to control and reactive monocytosis, we demonstrated that in CMML we obtained that kind of profile with an accumulation of classical monocyte at the detriment of the 2 other populations. And this was specific to the CMML sample that we have tested and led us to propose a new criterion for CMML diagnosis based on a relative accumulation of classical monocytes above 94% of the total monocyte count. I would like also to highlight that this abnormal partitioning of peripheral blood monocyte can be used as a biomarker for therapy response. As you can see here on the first line, for patients that are responders to hypomethylating agents, we observed a normalization of the 3 monocyte subset after treatment, with a decrease of the classical monocytes below the 94%. It is not the case for non-responders patients that remain with a CMML profile and an accumulation of classical monocytes. So this monocyte partitioning is in France used by more than 35 diagnosis centers, and an harmonization of practices has been created for routine laboratories. This work is now validated by several independent studies and by a European program validation, which also confirm our threshold at 94% of classical monocyte. So we can say that the monocyte partitioning can be now used as a new criterion for CMML diagnosis as recommended by the EHA, by the WHO classification, and the ICC classification since 2022. So now I would like to come back on these few samples here where authentical CMML didn't reach the 94% of classical monocyte accumulation. In fact, these CMML were co-occurred most of the time with an inflammatory diseases or an inflammatory state, which is not so rare in CMML because it concerns up to 20% of the CMML patient. In these cases, we observed this kind of profile that we named the bulbous aspect because there is, compared to a typical CMML, an accumulation of intermediate monocyte that blurred the 94% classical monocyte accumulation. What is of interest is that also in these cases, there is a disappearance of the non-classical monocyte, which can be interesting to quantify to better diagnose these CMML cases. But as it is very difficult to draw a gate between intermediate and non-classical monocyte that can be used after for standardization for routine laboratories, we prefer think about a new marker that labeled a population of cells that can be more easily quantified. And the marker that we have chosen was SLAN. SLAN is a membrane marker expressed by the monocyte, and among the monocyte, here in red, the SLAN-positive cells are restricted to the non-classical monocytes. Not all the classical monocytes express SLAN, about 50% of them, but it was enough to quantify them, and here we obtain that compared to control here, where we have a fraction of cells SLAN-positive non-classical monocyte, there is a decrease of this fraction for typical CMML and also for inflammatory CMML. We calculated the threshold at 1.7% of SLAN-positive non-classical monocyte, which diagnose all the CMML cases compared to reactive monocytosis and controls. So with that, we proposed a two-step algorithm for CMML diagnosis with a monocyte assay. The first step is looking at the classical monocyte percentage above the 94%, which is in favor of CMML diagnosis. And if it's not the case, but we observe a bulbous aspect and the SLAN-positive non-classical monocyte below the 1.7%, it is also in favor of a CMML diagnosis. Our next question was to understand the mechanism involved in this abnormal monocyte subset partitioning. And two main observations guided our reflection. The first one was the decrease of the non-classical monocyte in CMML suggested a differentiation blockage during the monocytopoiesis, and the demethylating agents restoring a normal monocyte subset repartition suggested an epigenetic mechanism. For the monocytopoiesis, if the first step of this differentiation is well established in the literature with the different transcription factors involved in the different stages, we don't know much about the monocyte subset production, and even their origin is controversial. One of the mechanisms that is proposed to explain the monocyte subset differentiation is named the conversion, and it has been validated in humans. It said that the monocyte derived the one from the other, with the classical monocyte that gives the intermediate monocyte and then the non-classical monocyte. And so we work on this mechanism in the CMML. And to make a long story short, we demonstrated that a microRNA, miR-150, and its target TET3 are involved in the regulation of the conversion between the classical monocyte toward the non-classical monocyte. In CMML, the expression of miR-150 is decreased, leading to a classical monocyte conversion blockage. And now, why do we have a decrease of miR-150 expression in CMML monocytes? We were looking for an epigenetic mechanism, and so we used histone-marked ChIP-seq analysis data to first define a promoter for miR-150. We find here a promoter that is transcriptionally active in monocytes for miR-150, which is hypermethylated in CMML classical monocyte compared to controls. This could explain why miR-150 expression is decreased in CMML monocyte and why we have this conversion blockage in CMML. So now for the end of my talk, I would like to move to another population of cells that we find different between the age-matched control and the CMML here. This population belongs to the neutrophil clusters. When we look more carefully at the expression marker of these cells, we found that these cells are immature neutrophils, and in particular, all the neutrophils here in age-matched control are CD15, CD16, whereas in CMML there is a fraction of them that are CD15, CD16 negative. This fraction is very heterogeneous in CMML samples, whereas in control it remains at a very low percentage. We then optimize a gating strategy for conventional flow cytometry to quantify this high-gram population in CMML blood in a large number of patients and controls, and we confirm the presence, the accumulation of high-gram in the peripheral blood of CMML patient compared to controls. About 50% of the CMML patient presented accumulation. This accumulation is of poor prognosis when we look at the survival probability of two groups of patients with an high or a low high-gram accumulation of cells. Then we wanted to understand why the presence of the high-gram population in blood can be of poor prognosis for CMML. And first, we observed that the membrane markers, the molecular markers, and their functionality in vitro were the same that the one that characterized the myeloid-derived suppressive cells from granulocytic lineage, or PMN MDSC. So these cells present immunosuppressive activity, which could explain their poor prognosis because they modify the adaptive response in a CMML patient. These cells belong to the leukemic clone. They express the mutation as the stem cells or the monocyte. And most of the time, the accumulation of IGRAN is correlated with the mutation of I6L1 and SRSF2. This clonal IGRAN present a high inflammatory activity, and among all the cytokine overexpressed by the IGRAN, we focused our attention on CXCL8 because it was the main cytokine overexpressed by this population of cells and oversecreted in the patient plasma. We then wanted to understand the impact of the oversecretion of CXCL8 in the plasma of the CMML patient on CMML development. And for that, we realized some in vitro proliferation assay in liquid culture or semi-solid culture with different doses of CXCL8. And we observed that in CD34 positive cells from healthy donors, wild-type cells, there is a decrease of proliferation in the presence of CXCL8, which is not the case for the CMML CD34 positive cells. Why the difference of sensitivity between these two kinds of cells? We look at the two receptors of CXCL8, which are CXCR1 and CXCR2. And we observe that at the mRNA level and at the protein level, there is a decrease of expression of the two receptors in the CMML cells compared to control. And this seems to be due to an epigenetic mechanism. So to conclude on this part, we observe an accumulation of immature granulocytes in the blood of 50% of the CMML patient that secrete a high level of CXCL8. And our hypothesis is that CXCL8 in a large concentration in plasma could promote the clonal cell expansion, the mutated cell expansion at the detriment of the wild-type cells due to a difference of sensitivity. So, in conclusion, using flow cytometry in routine is both an important tool for diagnosis and prognosis. For peripheral blood cells quantification first, the identification of the monocyte subset abnormal partition is a very interesting tool to diagnose CMML, and it can be refined by using the SLAN marker in case of inflammatory CMML. The flow quantification of circulating immature granulocyte identified a prognostic marker. And I would like also to highlight that it is interesting to also analyze by flow cytometry the bone marrow cells. It's not the better tool for the monocyte subset quantification, but it can detect other cells, like, for example, the plasmacytoid dendritic cells infiltration, which were demonstrated as a poor prognostic marker in CMML. So with that, I would like to thank all the members of our team in Gustave Roussy working on CMML, thanks to our collaborators, especially the patient and the clinician of the GFM for all the CMML samples, and thanks for your attention.
Thank you so much, Dorothe. We are moving on, and you remember that we have a Q&A session after this session. I'm happy to introduce Dr. Mrinal Patnaik. Dr. Patnaik is a physician scientist and professor of hematology in the Department of Hematology in Mayo Clinic, Rochester. And he is a senior member of the group that really pioneers many studies in this field. He will talk today about therapeutic targets in RAS-mediated proliferative CMML. Dr. Patnaik, please.
Thank you, Dr. Middleman. Good morning, ladies and gentlemen. Thank you for the opportunity to present today. I'm going to talk to you a little bit about RAS mutations and their therapeutic targeting in chronic myelomonocytic leukemia. These are my disclosure slides. Now, we've learned a lot about RAS mutations largely from the RASopathy syndrome. So the congenital diseases like Costello's, Noonan's, neurofibromatosis, all of these can be associated with either transient or sustained monocytosis and constitutive active signaling of the RAS molecules. And this is a photograph from Peru, Lima, where this gentleman was trying to fix a phone line, just telling you how complicated signaling involving the RAS pathway can be. Now, in hematological malignancies, RAS mutations have often been looked at as subclonal, not targetable, things that occur late during clonal evolution. But this is not the case when we deal with overlap neoplasms. Juvenile myelomonocytic leukemia is a bona fide RASopathy syndrome, and I hope at the end of this presentation I convince you that proliferative CMML is very akin to that, with a high dominance of RAS signaling, and it's important to focus on these aberrations. Now, a lot of RAS signaling development we have learned from colorectal cancer and lung cancer, where there's been a plethora of agents that may help us as we move along in the field. Today, we will be focusing not just on the RAS GTPases and downstream effectors of RAS, but also talk about SOS and SHP2 and the role that they may play in proliferative CMML. The slide on the left-hand panel here is highly encouraging. So with the Solve RAS initiative through the NCI, and as I said, a lot of work that has largely been driven from solid tumor groups, there are very encouraging groups here. These are the KRAS off inhibitors, drugs such as sotorasib and adagrasib, which have been FDA approved for the management of lung cancer and colon cancer with KRAS G12C mutations. The SOS1 inhibitors that are showing great activity in colorectal cancer and some forms of lung cancer, and then the SHP2 inhibitors that are also moving very rapidly down the line. But the most exciting group here are the RAS-on inhibitors, which can inhibit the GTPase regardless of steric conformation and can more importantly target KRAS G12D, which has been largely elusive from pharmacological inhibition. This is the KRAS G12C, these two compounds now. We've got follow-up data in lung and colorectal cancer with both sotorasib and adagrasib. They have a median duration of response of approximately 6 months, and very elaborate resistance mechanisms have made us even more aware of how these point mutations work, the stress on the contralateral allele and downstream amino acid residues that tend to mutate when you put a lot of pressure on this pathway. And then, of course, this case report that came out in the New England Journal of Medicine a few months ago, showing that even CAR-T therapy in NRAS pancreatic cancer led to significant debulking of the disease, opening up avenues that we never thought were possible, a few years ago when it came to RAS mutations. And this is probably the most exciting compound. This is the Miriatry MRTX133. It's a non-covalent KRAS G12D inhibitor, 5 nanomolar potency. We've done a few in vitro studies yet on CMML with the KRAS G12D, and the responses are outstanding. 700-fold selectivity for KRAS G12D over the wild-type KRAS. And most importantly, it binds to both active and inactive forms of KRAS G12D and is likely to have a much more sustained duration of response compared to the G12C inhibitors that we have tested. So in chronic myelomonocytic leukemia, a disease of aging, in my opinion at least, the incidence is similar to myeloproliferative neoplasms, the prevalence becoming much lower because a lot of them transform to acute myeloid leukemia and unfortunately pass away. The genomics has always traditionally defined epigenetic abnormalities, such as mutations in TET2 and ASXL1 and splicing, but there are subtypes of CMML where signaling aberrations, especially involving the RAS pathway, are dominant. And the most common abnormalities here include NRAS, Sybil, PTPN11, KRAS, and to some extent NF1. And as you can see that while canonically we see monocytosis developing because of TET2 or biallelic TET2, TET2 SRSF2 co-mutations, there are subtypes of CMML where NRAS can be detected very early on, even prior to some of the epigenetic signaling mutations that give rise to highly proliferative CMML subsets reminiscent of the pediatric counterpart, juvenile myelomonocytic leukemia. And while the conference has been really robust in terms of targeted therapies for myelodysplastic syndrome and AML, unfortunately, a lot of these have not translated down to CMML. Mutations in IDH are very uncommon. You heard a lot about splicing inhibitors. We'll have to see where the CLEC inhibitors move, but at least the H3B800 drug hasn't shown that much promise. FLT3 is uncommon. And when we looked at 1,000 patients with CMML, less than 1% had the KRAS G12C mutation. So although adagrasib and sotorasib are good drugs for this, this is not a mutation that we see enriched in our patient population at all. And the drug that has been used traditionally are hypomethylating agents. So azacitidine and decitabine largely on trials which were MDS predominant, including largely patients that had dysplastic CMML. And as Dr. Solari has shown that these drugs really don't modify the disease biology, with mutational allele burdens remaining unchanged in majority of patients. And the subset that really does well, as we have defined in this large set, are patients who are TET2 mutant ASXL1 wild type. So there is a subset of CMML. These are largely dysplastic. They're usually RAS wild type, which have very good outcomes in general, but if you treat them with azacitidine or decitabine, they have durable remissions. The longest responder I've had in my practice is 10 years now on azacitidine with this particular genotype. And as Dr. Itzykson has shown, I think one of the best studies to have come out, really showing that when you compare decitabine with hydroxyurea in patients with proliferative CMML, the benefit is really muted with no significant difference in overall survival and event-free survival. And MEK inhibition has been tried. I take you back to 2017. This was a trial where trametinib was used. It was an AML predominant trial, but it did have a CMML cohort that was RAS mutant, and only one patient in that group had a response, but the toxicity was significant. So not just diarrhea and skin rash. Over 3 to 7 weeks, a lot of people start dropping the ejection fraction because of off-kinase inhibition through trametinib. And then there is a Concerto trial. This is being run out in Salt Lake City, where they're trying a drug called cobimetinib, which is a MEK inhibitor in CMML, which is RAS mutant. And thus far, a small group, 4 of 6 accessible patients, one had a spleen response and one had an erythroid response, but more than 80% of these patients develop diarrhea from the drug. So we'll have to wait and see how this trial evolves over the next several months. But this is where we got involved a few years ago. Our lab asked the question, for long, I see Dr. Bennett here, the FAB had always divided CMML into proliferative and dysplastic. There were clear phenotypic features, and we asked this question, what is the rationale for doing so? Not just survival benefits and leukemic transformation benefits, but when you go into the genomic structure of these two entities, what you find is that proliferative CMML is essentially a RASopathy. Apart from a subset with the JAK2 mutant, a lot of these, the red bars, will show that they have RAS mutations. In this paper that we published in Nature Communications, we also showed that there is a variant allele fraction cutoff that correlates with the proliferative phenotype. It's 30% for NRAS and 20% for the other RAS regulator mutations when you start seeing this effect more clearly. And when you do whole exome sequencing, including all the constituents of the RAS pathway as ensembled in KEGG, you can see that more than 80% of proliferative CMML is actually driven by minor or major RAS pathway mutations. We then asked the question that, are these really subclonal? Should they be ignored, or can these be early driver events? And using our whole exome sequencing data as well as single colony assays, we showed that there are proliferative CMML subtypes where RAS mutations come even before ASXL1 and TET2. And I think this is exemplified well on this slide where we sequence 50 single colonies, and you can see that the ancestral clone had NRAS and TET2 before the occurrence of the frameshift mutation that occurred in ASXL1. We've also, with the help of Jing Zhang at University of Wisconsin in Madison, developed 2 mouse models now that faithfully transgenic mouse models that recapitulate the disease. The most encouraging is the NRAS G12D ASXL1 FLOX, the VAV1 CRE, which is now allowing us to do a lot more of our drug work also in the context of xenografts. We then did RNA sequencing to ask the question, are there any transcriptomic differences? And as you can see here, proliferative and dysplastic aligned into 2 separate categories here. The proliferative subtype was over-enriched in mitotic checkpoint regulators like PLK1 and V1. And here, when you see an increase in NRAS WAF, the PLK1 expression went up significantly. And here we knocked down NRAS and KRAS and overexpressed it, showing that there was a clear dynamic relationship between PLK1 expression and RAS mutations that was not seen in JAK2, because JAK2 can form about 10% of proliferative CMML, which has a very unique phenotype with high hemoglobin levels and high platelet counts. We then did some epigenetic work over here, and this is ChIP-seq for 5 different marks. And I can just point out here that what really stood out in PLK1 and B1 at the promoter sites was an over-enrichment of monomethylation of H3K4. So H3K4 was dynamic regulated. When you knock down NRAS, you see the occupancy go down. When you overexpress it, you see the occupancy go up. And H3K27 was pretty similar between the two. So we asked the question, what was driving this? And if you look at monomethylation of H3K4, it's by the COMPASS family, so the KMT2As, or it could be a deregulation of the KDM, the demethylases that regulate this process. And by going back to RNA-seq and doing functional work, including ChIP-PCR, we found that it was an intact KMT2A or menin, the KMT2A menin complex that was bound to these promoter sites, causing monomethylation of H3K4, increasing PLK1 expression, again, something that was very specific to NRAS and the RAS pathway and not seen with JAK2. So then we asked the question is, can this be translated from the bench to the bedside? When we inhibit PLK1, we saw a decrease in colony growth. But here's the in vitro work. These are 10 NRAS mutant proliferative CMML and 10 NRAS wild-type dysplastic CMML, showing a clear advantage of using PLK1 inhibition. This was with a drug called volasertib, with IC50s in the median range of 25 to 30 nanomoles. And then with the help of Dr. Padron, when we did the xenografting, we saw this is the spleen, this is the bone marrow. Again, with volasertib, you can see this is human CD45. 163 is a macrophage marker, 14 is a monocyte marker, and there was a clear improvement both in the spleen and in the bone marrow, reduction in spleen volumes, as well as flow cytometric evidence that this may be an opportune and an effective targeting approach. So then we identified onvansertib. This is a highly selective PLK1 inhibitor. It's novel, it's oral. There is early phase data in acute myeloid leukemia in combination with decitabine, and we did further xenografts and in vitro studies, including resistance mechanisms with EZH2 and FLT3, and have now been able to launch a phase 1 clinical trial. So MC210807 is a phase 1 study that enrolls patients with relapsed refractory or intolerant myeloproliferative CMML enriched in RAS pathway mutations. We have 3 dose levels, and we are basing this study very uniquely, not just on maximal tolerated dose, but also on targeting efficacy by looking at the phosphorylation of TCTP, which is a natural product of this pathway. We have now dosed 2 patients on this trial. Patient 1 has completed 6 milligram per meter square, tolerated it well. There has been a reduction in spleen volume, and the second patient has just started treatment. This has also led to an R01 grant looking at synergy potential mechanisms of response and resistance. And what we are now working on is trying to see whether onvansertib can synergize the NMT methyltransferase inhibitors. We have avodasertib, which is a WEE1 inhibitor that's following suit through our in vitro and in vivo studies. And we are very excited to work with SOS1, SHP2, and the KRAS G12D inhibitors. So hopefully, the years that we put in over here can help produce therapeutic targeting of RAS as a reality in myeloproliferative CMML, and maybe some of this can translate over to JMML. So ladies and gentlemen, thank you for your time. I really like to acknowledge all our patients who have taken part in this, the myeloid malignancies group, Eric Solari, Eric Padron, Jing Zhang, and several of the other collaborators. So thank you.
Thank you very much, Mrinal. I'm very pleased now to welcome Raphaël Itzykson. Raphaël is professor of hematology at St. Louis Hospital. He's a physician scientist, an expert in myeloid malignancy pathogenesis, and in charge of CMML trials in GFM. Thank you, Raphaël.
Thank you, Eric. Thank you all for this great opportunity to meet with great colleagues and friends and to share this excitement about new models and pathways to target in CMML. I hope I'm not going to disappoint you too much with what I'm going to show now. These are my disclosures. So the title of my topic was quite broad, so I'm going to try to address 2 simple questions. What is the role of allogeneic stem cell transplantation in CMML? And in patients that are not eligible for transplant, what is truly the role of single-agent hypomethylating agents? So we addressed the question of allogeneic stem cell transplantation timing in CMML, bearing in mind the importance of similar studies that had been conducted in myelodysplastic syndromes that showed that the benefit of allogeneic stem cell transplantation was restricted to patients with higher risk MDS. To design a similar study for CMML based on retrospective data, we took advantage of the international consortium dataset that Eric Padron and a number of our American and European colleagues had gathered across the 2 recent decades, and worked in collaboration with EBMT to get more granularity on the post-transplant outcome of patients that were transplanted. We focused our studies on patients younger than 70 years of age that were diagnosed from 2000 to 2014, and with available follow-up data ended up with a cohort of 730 patients with newly diagnosed CMML with follow-up data since diagnosis, and 384 EBMT patients where we had follow-up data beyond allogeneic stem cell transplantation. The first, so we merged the 2 cohorts together, and we first performed univariable time-dependent analysis, grouping the patients into lower versus higher risk based on the CMML prognostic scoring system that has been designed by our Italian and Spanish colleagues, simply because it does not involve molecular parameters that were not broadly available in these 2 cohorts. Patients with low or intermediate 1 CPSS risk were considered lower risk, and intermediate 2 and high were binned into the higher risk category. What you can see in this univariable Simon-Makish plot is that whereas there was no significant benefit of allogeneic stem cell transplantation in the higher risk, seemingly in this univariable analysis, there was a detrimental impact of allogeneic transplantation in patients with lower risk. And what you can see from those survival curves, even though these are Simon-Makish curves, so not that trivial to interpret, is that actually the impact on survival of transplantation is not constant over time. And this led to difficulties in interpreting multivariable Cox model. And it's a constant warning that we tend to use these multivariable analyses without sometimes forgetting a number of their core assumptions from a methodological standpoint. So to overcome this limitation, our very clever collaborators in the stats department of EBMT designed a multi-state model that allows to take into consideration all outcome data of all patients regardless of timing. Unfortunately, we did not have information on progression of CMML, say from CMML1 to CMML2, for instance, between diagnosis and transplantation. The only progression information we had was transformation to AML. So there's a lack of granularity here in appreciating transitions in disease progression in this study. So we could define the state of the patient over time, being in CMML or in the transformed state, having been transplanted or not. And this nicely allows to have individualized survival outcomes per patient, considering the probability at each time point to be alive with CMML with or without transplantation, alive after AML, unfortunately, a much less likely probability, and so forth. And this allowed us to compare the outcome of patients at different time points after diagnosis in a state where they have been previously transplanted or not. And this is what is summarized here on this plot for patients on the left. That would be a typical 60-year-old patient, and on the right plot, a typical 70-year-old patient. So let me walk you through these graphs that are not completely intuitive to interpret. So we looked at the difference in predicted survival after allogeneic stem cell transplantation or without allogeneic stem cell transplantation at 6, 12, 18, or 24 months from diagnosis. So perhaps for our clinical practice, the most important to interpret point is 6 months after diagnosis. Otherwise, do I expect to see a survival benefit if I transplant a patient within the first 6 months from diagnosis? And as you could see, there was a clear survival benefit for upfront transplantation in male patients with higher risk CMML based on the CPSS, regardless of age. And the survival benefit for females was not that clear, even though the trend was positive over time. There is no super clear explanation for this gender bias, aside from a trivial methodological one, which is that obviously in this CMML cohort, males were widely overrepresented. So to summarize the findings of this study, there is absolutely no benefit for early allogeneic hematopoietic cell transplantation in low-risk CMML. The benefit in higher-risk CMML is more pronounced in males, and designing and conducting these studies showed the many caveats of retrospective studies that we are aware of, but these do warrant the need for prospective studies of allogeneic transplantation-based interventions in these patients. And obviously, these studies will have to account for genetics and CMML genetics and obviously data on more recent transplantation techniques such as alternative donors and haploidentical stem cell transplantation. So in the second part of my talk, I'm gonna delve into more details of the Dakota trial that Mrinal presented in his previous talk, and walk you through a little bit of the rationale behind this study. So this is, to the best of my knowledge, the first CMML-specific randomized clinical trials that was ever conducted, and this was done by Eric Wattel and a number of GFM investigators in the 1990s, comparing two different cytoreductive strategies in CMML, hydroxyurea versus oral etoposide. And this trial had, per protocol, defined response criteria that were based on what would become the IWG criteria for MDS, but also accounting for reduction in spleen size and extramedullary symptoms, as well as protocol-specific criteria for advanced disease based on the prognostic scoring system that were used in CMML at that time, and that I should say do not underperform more modern prognostic systems that do not account for molecular markers. Using these protocol-specific response criteria, 60% of patients in the Hydrea arm underwent some form of response, including 20% of patients that had complete remission because they were mostly proliferative without marked cytopenias or bone marrow blast excess. And there was a very significant difference in overall survival in this trial that by then was mostly interpreted as a difference in tolerability of the two drugs because of the mucositis induced by oral etoposide. Obviously, following the AZA-01 trials and other trials with decitabine, there was a surge of interest for single-agent hypomethylating agents in CMML, a number of retrospective or non-randomized prospective studies that collectively, I collected 70 of those, but the number keeps rising. Collectively, these studies report overall response rate in the 50% range, including 10 to 25% in the most optimistic reports, complete remission. There were occasional reports of regression of myeloproliferative features, but these was poorly captured in studies that mostly used MDS criteria, and in two studies that used propensity score matching to compare azacitidine and decitabine, there was no notable differences between these two hypomethylating agents. And our Austrian colleagues conducted a very thoughtful retrospective analysis on a very large cohort of patients, suggesting a survival advantage of single-agent hypomethylating agents over hydroxyurea. So there was a lot of momentum to randomize, actually, in patients where there was no label for hypomethylating agents in Europe, that is proliferative CMML, to compare a hypomethylating agent versus cytoreduction with hydroxyurea. This was conducted with single-agent decitabine using the conventional 5-day regimen of decitabine, and the primary endpoint for this trial was powered for event-free survival. Let me walk you through the key eligibility criteria so that we know which patient we're talking about, and this is important to interpret the results. These were patients with proliferative disease using the criteria that was proposed by the FAB, but also advanced disease based on bone marrow blast excess, cytogenetic abnormalities, profound anemia, thrombocytopenia, or splenomegaly. And patients could and did receive a brief course of hydroxyurea prior to randomization. These were the typical CMML population in terms of age distribution. 1/3 of patients had CMML2, and as you can appreciate, these patients were really proliferative with a median white blood cell count of more than 30 gigs per liter in both arms, and roughly 40% of them received prior Hydrea for a few weeks before the trial. So with a median follow-up of 17.5 months, a patient had received a median of 5 decitabine cycle, which is not that huge and already points to a limitation of the feasibility of this treatment in this cohort compared to 6 28-day cycles of Hydrea in the Hydrea arm. And as we've previously shown, there was no difference in the primary endpoint of event-free survival, and neither on overall survival, even though the trial was not powered for such a comparison. There was virtually no difference. We wondered whether this was due to the fact that many patients after progression in the Hydrea arm had went on to receive a hypomethylating agent. That was the case in roughly 60% of the Hydrea arm patients, but that did not affect our conclusion. Neither did censoring after allogeneic transplantation for the few patients that did undergo transplant. Subgroup analyses considering bone marrow blast excess, platelets, or hemoglobin levels, CPSS, GFM, or CPSS, molecular CPSS scores, did not identify a subgroup that robustly benefits from decitabine over hydrea. There's more study there with additional biomarkers, as you've seen. But when we tried to understand better what had happened in the decitabine arm, it soon became clear that there were more responses in the decitabine arm. We had not missed the usual response pattern of hypomethylating agents, including a slightly significant but modest complete remission rate in that patient population. What we saw when doing competitive risk analysis was that there was indeed a reduction in the risk of cumulative risk of progression or AML transformation with decitabine over hydroxyurea, but this was offset by toxicity, actually, death that was not related to progression or transformation. So toxicity is probably a strong word here in the decitabine arm. That was mostly due with an excess, of infectious events and a significant but modest increase in the cardiovascular event rate. So as you know, and Ken Figueroa already showed you, there are some exciting correlative biomarker studies that are ongoing, but it is clear that there is much progress to be done to translate the superior response rate we nevertheless observed with hypomethylating agents into meaningful survival benefit in proliferative CMML. This could be through drug combinations or improved management of this treatment in patients that are actually quite frail, even though they are not necessarily neutropenic. And we hope that ongoing studies will tell us whether HMA-based combinations are indeed the way to go in CMML, or whether we should switch to totally different approaches. And I'm sure you're convinced that now we have in our hands new preclinical models and targets that will make the future somewhat brighter for our CMML patients. And with that, I would like to acknowledge all the European EMSCO group, the Italian group, FISM, the Dutch, German MDS group, and the GFM investigators that collectively led the Dakota trial, the GFM staff that coordinated the study, as well as our tremendous international CMML cohort collaborators and EBMTs, investigators. Thanks for your attention.
Thanks a lot, Rafa. As a young physician, I looked at my colleagues treating children. I always was, frustrated because they always were 2 steps ahead of us, and they always taught us lessons how to treat better than we in adult hematology. So even with MDS, my colleagues remind me that although not that common, childhood MDS and JMML is still around, and it's not probably that rare, and we can learn some lessons. So
I am very pleased now to welcome Françoise Porteux. She's the head of an INSERM unit at Gustave Roussy Cancer Center in Villejuif, France, and she's an expert in stem cell biology with strong interest in the aging of stem cells. So, Françoise.
Thank you, Eric. Good morning, everyone. No, not that. Okay. How to switch? Doesn't work. Can I have the next slide? Because it doesn't work, no? Maybe here. That's maybe this, no? I'm sorry, but I can't do it. Ah, here. Okay, sorry. I have nothing to disclose. So as you heard several times this morning and yesterday, CMML is a disease of aging. So the question we ask in the lab is, can we take advantage of studies which aimed at deciphering the mechanism of HSC aging to better understand CMML and why CMML occurs? So we previously found that aging as well as many stress-induced premature aging, such as irradiation or chronic inflammatory stress, directly induce the expression of retroelements in HSCs, either in the mouse or in human, in all cases. So I will come back to that. The retroelements, they are 40 to 50% of our genome, and they include LTR, which are endogenous retroviruses, and line and signs. Sorry to go back here. So retroelement expression is regulated by epigenetic mechanism, and particularly by heterochromatin, which is composed of DNA methylation and the repressive mark H3K9-3 and H3K9-2. And this heterochromatin is very important to maintain identity of the cells, and is a hallmark of aging and senescence in cells and model organisms. And this is also true in HSCs, where we found that during aging in human and mice HSC, there is a decrease of H3K9-3. And this is also true by a direct action of agents inducing premature aging of HSCs. And the decrease of H3K9-3 occurs mainly at retroelements such as line 1 and LTRs. So the decrease of H3K9-3 and heterochromatin and expression of retroelements are hallmarks of HSC aging. But what is the status of heterochromatin and retroelements in malignant HSCs such as CMML? And can we find implications for the treatment of these diseases? So to answer this question, first I have to come back a little bit on the role of retroelement, and particularly in cancer cells. So retroelement, you must imagine that they are strong gene, which can be the case indeed because, which can be, which can be the case indeed because they can induce genomic instability, such as insertion and mutation, but also they are very also important in transcriptomic alteration. They can behave as enhancers with oncogenic potential, silencers, splicers, and so on. So they can drive an oncogenic program for which the cancer cells are addicted to. And however, as all type of oncogenes, if the expression goes above a certain threshold, these retroelements are a very strong anti-tumoral. And this may be why it has been selected for during evolution. And so because they will activate P53 due to genomic instability leading to cell growth arrest, and also another very strongly conserved anti-tumoral pathway in lifehood, actually, is viral induction, because they can induce double-strand RNA or cDNA in the cytosol, and this can be seen as viruses by our cells, leading to interferon production and NF-kappa-B-induced cytokine, cell death, senescence, and senescence-associated secretory phenotype. So this can open a therapeutic opportunity for massive induction of retroelement, which have been used with DNA demethylating agent in some cancer cells and some solid cancers, actually. And another thing important is because they are so anti-tumoral, the cancer cell during evolution will try to maintain this state with a few retroelements as an oncogenic program and preventing that strong action. And the easiest way to do that is to block the expression of retroelement by repressive marks, such as DNA methylation or heterochromatin marks. So in CMML, as you heard also, hypomethylating agent treatment actually do not eradicate HAC. So we wonder why is that, and is it because we cannot induce sufficient amount of retroelement in these cells? And if so, is it because of an epigenetic switch, a repressive mark blocking this retroelement and preventing the viral mimicry and the immune cell death? So we looked at that, and first we look at heterochromatin status in CMML cells. As you can see here, compared to elderly CD34 cells, we were surprised to see that the level of H3 K9M3 is even more decreased than in aged control, which was surprising because without heterochromatin, it's difficult to survive and to keep your cell identity. So we look at another mark, and we found that actually there is a very strong increase of H3 K9M2, and that concerns most patients, actually, all the one we tested but one. And so, interestingly, we also found that T2KO mice who develop CMML-like disease with age show this increase in H3 K9M2 starting middle age, before the onset of the disease, and while old mice, middle-aged wild-type mice do not do so. And also, this increase is even higher in T2 SRSF2 KI mice, with an increase of H3 K9M2 in HAC, and these mice develop CMML disease more strongly and with a better, greater incidence. So we looked at heterochromatin in CMML HSPCs using ATAC-seq, and compared to elderly control, we found that there is some amount of closed and open region. But looking at the repeats particularly, we found that there is a gain of opening of chromatin at satellite repeats, which goes well with a decrease of H3 K9M3, actually. And there is, when looking at the retro element, we found that all of them actually are rather in a close conformation compared to controls. And this occurs at line, but line 1, and most of the ERV families are in a close conformation. So the hypothesis that this close conformation could be due to the increase of H3 K9M2 at this element, closing them. And so we wonder whether we could use inhibitors of this mark, using inhibitor of G9A GLP complex, in cooperation with hypomethylating agent to open the chromatin at retro elements. So we took HSPCs or HSCs from CMML cells and cultivate them in the presence of the citabine or 5-azacitidine, in the presence of absence or of G9A GLP inhibitor of different types. And we use ATAC-seq and RNA-seq to look what's going on. And so in ATAC-seq, we found that the combination really opens here now the chromatins with most of the loci which are open. And looking at repeats, we found that now that all the repeats are in an open chromatin conformation, and this is the case particularly for all LTR. So focusing on endogenous retroviruses, we thought that these retroviruses can be expressed in the cytosol. And we look at RNA-seq, and indeed, we found that although each inhibitor alone doesn't have much effect on the expression of retroelement, the combination really synergistically induces many of them, which are specific really for the combination. Now, looking at gene expression, we found this is also the same case in the presence of the combination. The most tremendous amounts of genes are upregulated in the combination of inhibitor only, while few are regulated by decitabine or G9A GLP inhibitor alone. And among the upregulated genes, we found all mark of apoptosis, P53 response, but also the interferon and inflammatory responses. As you can see here, there are also synergistically some genes which are closed only by the combination and not by inhibitor alone, and these comprise genes involved in the proliferation, suggesting the combination can kill the cells. And also, we also looked at the activation of the interferon signaling pathway directly. Okay, because I took time with the slides. Okay, so let's keep. Let's keep. So the function here, you can see that the combination can kill the cells and decrease the clonogenicity of CMML patient cell without affecting the control. And this is due to the production of interferon intracellularly, as it can be rescued by anti-interferon receptor. Okay, so looking at the cells remaining after the combination in the wells in different types of patients, we found that the genotype of the cells remaining in the wells are mostly wild-type cells, suggesting that the combination, but not inhibitor alone, has killed only mutated cells. And this is also, okay, what we found. What is that? I don't know. This is what we found also in TET2 mice, where the increase in H3 canine number 2 correlates with the increased sensitivities of the combination, and this is true also here in TET2 SRSF2 mice, where the combination kills here all the mutated cells, but not the wild-type cells. Okay, so to finish, I'd like to thank everybody who did this work, particularly Donia Idawi and all the team, of course, and you for waking up. Thank you.
Okay, thank you. Last but not least, it's a pleasure to and refreshing to invite Dr. Liang Liang from the University of Guangzhou in China, but is he here with us, or Dr. Gale? So this is Dr., as you can see, this is not Dr. Liang Liang. This is Dr. Bob Gale, who is collaborating with this group from University of Guangzhou, and the topic will be SRSF2 and TET2 commutations.
Just a few preliminary comments. Firstly, many of you will appreciate that I am not Yang Liang, as Moshe has mentioned. Secondly, this is the first time in 70 years that I've had to compete with a coronation. I'm sure that most of you would be rather watching King Charles III's coronation, so I'll try to be brief. These are our conflicts of interest. So this is the mutation topography, and I think all of you are aware of this. Splicing factor mutations and epigenetic regulators are the most common, but about 25% of patients have a co-mutation. So this is just one example of many where you can see, whoops, sorry.
The green button in the middle.
Here is the variable allele frequency. So these are SRSF2 mutated, TET mutated variable allele frequency and monocytosis. And you can see this very nice correlation. The red dots represent patients with myelodysplastic neoplasm, and the green dots are myeloproliferative neoplasm. Now, the focus of our study is to try to understand how does this co-mutation in a single cell or a single clone, how does that drive towards a CMML-like phenotype. And very simply put, we started with a small number of subjects. We had 4 subjects that had a co-mutation, and then 4 that have mutation in SRSF2, but wild-type TET2. Bone marrow cells extract RNA for transcriptome analysis, and then single-cell nuclei for ATAC-seq, so we could see the regulatory features. And when we look at differentially expressed genes between these 2 cohorts, we identified 621 differentially expressed genes. These are the most downregulated genes. These are the most upregulated genes. And when we do KEGG analysis of those 621 genes, KEGG biological ontogeny analysis, then you can see that the two things that pop up most dramatically are hematopoietic cell lineage-related genes and cytokine receptor interrelated genes. Now, we had a very small data set, as I mentioned, and so the next thing we did was to focus our attention on a publicly available data set and then look for overlap between these two data sets. And we identified 18 genes that were predominantly either hematopoietic cell lineage-related genes or cytokine receptor interaction-related genes. And now, sort of turning to the regulatory aspect of this. So we were able to get good single-cell data on about 50,000 individual cells. And using the gene expression profiling of cell types, we could identify 16 cell types. You see them displayed here, predominantly, but not exclusively, related to myelopoiesis. There are some cell types that are related to lymphopoiesis as well. Now, I apologize for this. Let me take you through it. I realize people can't read the details, but this is a pseudo heat map ordering of the myeloid lineage trajectory. So here you have SRSF2 mutated with wild-type TET2, and here you have it, the co-mutated single cells. And we look at transcription factor motifs and gene activity. And I just want to direct, if you look at the transcription factor motifs, they are not extraordinarily different. But if you look at the gene activity motifs, you see this dramatic difference here. And the major focus, the major difference, is in IL interleukin 1B and NLRP3. So as I go on, you'll see why we focused on these two. So Professor Itzykson and others have published data that when you have a TET2 mutation with or without an SRS2 mutation, you have a drive towards myelopoiesis at the expense of erythropoiesis and thrombopoiesis. So that's sort of the background for what I'm going to say in the next few slides. So now we are looking at hematopoietic stem and progenitor cells, single-cell ATCs. And we found about 20,000 differentially expressed genes when we look at this. And using single-cell ATAC, it was very clear that the CEBP family of transcription factors, the CCATT enhancer binding proteins, that are well described as being important in hematopoietic cell development, that they were the predominant transcription factors that were involved in the expression of interleukin 1 alpha and beta and in NLRP3. So this is a geo-annotated bubble plot. And you can see here that the interleukin 1 mediated signaling pathway, which has a very small number of genes, has a very low p-value. So they sort of confirm what I've told you up to this point, that hematopoietic cell-related genes, lineage genes, and cytokine interactions, particularly IL-1 alpha and beta, are what is driving this movement towards a CMML phenotype in patients with myelodysplastic neoplasm. So I just give you a few examples. If you look up here, this is where you have RSF2 mutated and wild type, and here is the co-mutation. These are in K562 cells that we put a construct in to create an artificial example of what happens in the co-mutated, naturally occurring CMML. So, for example, you see, this is the CFU colony formation when you have a wild type TET2. But when you have the mutated TET2, you have this markedly increased number. So that's this column compared to this column. And this is just HEL cells, just showing exactly the same phenomenon. So this is driving proliferation. And it is at the same time decreasing apoptosis. So again, here is the decrease. You can sort of see the increase in proliferation because of a decrease in apoptosis in two different cell lines. Now, these are normal hematopoietic stem cells that are now cultured with IL-1A alpha or IL-1A beta, and I'm just showing you one of many concentration curves. And here they are. You can see this increase in proliferation compared to the control vehicle cultures. Again, I apologize because this is a complex slide, but I just direct your attention to a few things. If you look at CFU gems, you can see that when you add IL-1 alpha or IL-1 beta, you markedly increase the number of CFU gems. And you can see that here. Here's the control. Here's CFUEs, CFU GMs. This is the control. And now you see IL-1 alpha, for example, and this tremendous increase in the number of CFU GMs and CFU gems. But if you wash the cells then and then replate them, you can see that you lose these effects. So it's driven by the presence of IL-1 alpha and beta. And again, this is a complex slide, and I just sort of take you through it for 1 second. The idea here is just, this is IL-1 alpha, and this is IL-1 beta. And if you look here at CD34, which we can sort of consider a marker of immature cells, you can see that it's being driven down by increasing concentrations, whereas CD11B and CD14, they are being driven up. And the same thing is true interleukin 1 beta. And if you look at the protein level, then you can see, now here are two different cell lines, and this is NLRP3 mediated inflammasome signaling pathway. So that is the driver of this increased concentration of the interleukin 1 alpha and beta. So if you look here, you can see this here. Let's just look at the 1,000 nanogram column. You can see this increase in NRLP3. You see this marked increase in interleukin 1 beta and in the cleaved product. And virtually the same thing is occurring down here. So let me just give you our conclusions so far. So SRSF2 mutated, TET2 mutated in the same cell. I mean, that's the important point. In the same cell, but not in different subclones. It drives by the dysplastic neoplasm towards a CMML phenotype. The co-mutation in the same clone is associated with an increased activity of the CEBP transcription factor family in myeloid stem cells, resulting in increased transcription of NRLP3 and interleukin-1 beta, and to some lesser extent, interleukin-1 alpha. Now, the IL-1 beta and the cleaved product interacts with receptors on myeloid stem and progenitor cells, increasing proliferation and decreasing apoptosis. And the result, as I started off, is that it drives the clone towards a CMML phenotype in myelodysplastic neoplasms. So thank you for your attention.
Thank you, Bob.
You can stay on the stage. I think when we are going to call all the speakers for a few minutes of questions. We have a question in the chat also. And
I think this is for Christian.
for Christian, yes. You want to?
No, it's okay.
Be sure we have all the chair. Have a seat.
We ask to answer the first question.
So yes, the first question is for you, Christian. It's in the chat. Zia Basha, she is asking if you are aware of any trial demonstrating efficacy of decitabine in JMML.
Efficacy of? Can you say that again?
Of DAC, decitabine.
I'm not aware of an actual trial. I mean, it has been given in compassionate use situations, but we do not have systematic data. I would assume that it is probably as effective as azacitidine is.
Okay. Yes, Michael.
Good morning. That was a really nice session. Thank you. Dr. Flotho, you taught me quite a bit about JMML. I didn't really recognize the NRAS good risk cohort. And I'm thinking of, in taking care of acute leukemia, the core binding factor of leukemia is the association with NRAS and good risk. So this is the second example now of a RAS family mutant, which in my mind should be connoting bad risk, but actually it's the opposite. Do you have any idea of the mechanism behind this?
I don't, but my caveat would be to say that in the CVF leukemias, I think the NRAS is sort of a subclonal secondary mutation, because the driver obviously is the CBF translocational mutation, whereas in JMML the NRAS mutation is really the driver. And majority of the NRAS cases we do not see any cooperating mutations. So I think that the concept is really different here.
Thank you. It's a question for Françoise Porto. Congratulations, very beautiful data. My question is related to whether you want to compare the effect on heterochromatin by the HMAs to some other drugs like interferon itself or something, or some other drugs, because it's a very interesting point. A lot of genes and a lot of new genes are upregulated. I would like to understand whether you compare to other treatments and other drugs.
No, I did not. No, I did not. That for sure that HME alone do not activate much of this interferon pathway, and you need really to have heterochromatin inhibitors. But also I didn't try to kill the cells with interferon. But interferon itself is very toxic, so I don't know if we can add it to it, though I didn't try anything else.
Thank you.
What are the mutational characteristics of the myeloproliferative and dysplastic type of CMML?
So the myeloproliferative CMML is really enriched in signaling mutations. So a lot of these, almost 70% of them will have oncogenic RAS pathway mutations, NRAS being the most common, CBL, PTPN11, KRAS, NF1. There's a subset of these myeloproliferative that are also driven by JAK2 V617F. They tend to have a different phenotype, the MEG morphology, hemoglobin. Very, very uncommon to see drivers such as MPL and CALR in CMML. Whereas in the dysplastic phenotype, you're more likely to encounter splicing, epigenetic modifiers, so mutations in TET2, SRSF2, followed by DNMT3A, SF3B1, RUNX1. So those are some of the differences, but there are overlaps, and as I pointed out in my presentation, these mutations should not be binarized. It also depends on their variant allele fractions and the clonal complexity, which can better define these phenotypes.
Good morning. We heard an excellent talk this morning from Dr. Eric about the PDX model in the MDS, and this is very useful for the drug development screening, also for diagnosis or even for the prognosis of the patient. And I'm just wondering, there's a similar methodology using the three-dimensional culture as the tumor organoid. So have you tried this methodology and compared with the PDX model? Thank you.
It's a great question. The answer is we are starting that process. I'm assuming you're referring to the recent paper that used iPSCs to create organoids mimicking the bone marrows. But yeah, I think it's an important question, and I think it's related to my first slide, which is choosing the right model for the right question. And there certainly is a role for organoids that's probably distinct to that of PDX, but complementary. Thank you.
I'll take the liberty and I will try to be quite provocative, since we are in an era of changes and we learn more and more. We know more about genetics, immunophenotyping, and we know really more. Maybe we might change the paradigm and stop doing bone marrows. Maybe bone marrow, at least in CMML patients, is not necessary anymore. So I would like all the speakers maybe shortly to refer to that question. Maybe we should change our diagnostic paradigm. Would you like to start, Dr. Patnaik?
I think I'll start. I don't think we're ready to do that yet, and I'll tell you my thoughts.
Because you're too conservative.
I'm very conservative, I agree. Old school. But I think, the bone marrow blast enumeration, they don't always correlate, the circulating blasts and the bone marrow blasts. And as Eric and our group have collaborated and shown there are other features in the bone marrow like plasmacytoid dendritic cell islands, even diagnostic features that could aid separating CMML from MPN with monocytosis.
So let's wait for the next meeting for that.
Next meeting, probably.
Eric?
But there could be other views to that.
Eric, what do you think? Raphaël?
I think we should still investigate the bone marrow. The question is whether we'll still be doing that by doing biopsies or doing aspirates. I do think, we've seen this, it's still very preliminary, but we now have some insights based on patients with clonal hematopoiesis that, there are distinct niches and there could be heterogeneity within the bone marrow. So hopefully we'll end up having, virtual biopsies and whole body imaging of the bone marrow that will allow us. That would be my future vision.
Dorothe, do you agree?
So of course, yes, I like to work with blood cells and peripheral blood cells, and I think some important information come from this part of the organism. But at the end, we want to see if clonal cells, mature clonal cells, are able to act on stem cells also. And for that, we have to look at the bone marrow and understand better all the microenvironments of the bone marrow. The one coming from the blood circulation, the one like PDC that are in the bone marrow.
Okay, thank you. Well, the big bosses are showing us that we have to, last comment, because we have to conclude the session.
Oh, okay. So I would just say that while I agree we should still do a bone marrow, perhaps a slightly less provocative consideration could be using peripheral blood evaluation to inform whether a bone marrow is necessary in certain patients, simply because the diagnostic capability of the flow cytometry assay and mutation assessment is so good. So perhaps not removing a bone marrow biopsy from the diagnosis altogether, but putting it in an algorithm where peripheral blood informs it.
I think it's a nice conclusion to end the session. So thank you so much. Thank you, Professor Solari, and thank you, the audience. Bye-bye.